Hi everybody. Let's talk about malaria today. Malaria is a life-threatening infectious disease caused by a protozoa, Plasmodium. Nearly 200 million people get infected and up to 600,000 die each year. There are more than 200 Plasmodium species but only 5 cause infections in humans. Plasmodium falciparum, Plasmodium malariae, Plasmodium vivax, Plasmodium ovale, Plasmodium knowlesi. Malaria infection. Female Anopheles mosquito, which is the carrier, injects malaria, in the form of sporozoites, into the circulation of the human being. The sporozoites pass rapidly into the human liver where they multiply asexually inside the hepatocytes. The sporozoites grow, divide, and yield tens of thousands merozoites in every liver cell. These merozoites leave the liver cells and enter the bloodstream. While some remain for few days to years are called hypnozoites, which causes relapse by Plasmodium vivax and ovale. In the blood, the merozoites attack red blood cells, erythrocytes, and multiply inside them again until the red blood cells erupts, releasing thousands of merozoites further. They then further attack more erythrocytes. This cycle is repeated many times. At this stage, the affected person will show symptoms of malaria. Some of the infected blood cells leave the asexual mold rather than replicating. The merozoites in these cells change into sexual arrangements of the parasite, called male and female gametocytes. When an uninfected mosquito bites an infected human being, it consumes the gametocytes in the bloodstream. They are further matured into gametes which fuses to form diploid zygotes, which further matures to oocyst. Thousands of active sporozoites develop inside the oocyst. The oocyst ultimately bursts, discharging sporozoites into the body cavity that transport to the mosquito's salivary glands. The life cycle of malaria repeats again when an infected mosquito bites a human being. The biggest risk factor associated with malaria is location. The highest number of malaria cases with the deadliest of associated infection complications are most notably seen in the Asian subcontinent, African countries, south of the Sahara Desert, Haiti, the Solomon Islands and Papua New Guinea, who are pregnant are at increased risk of malaria infection. There are several proposed reasons for this, including a lowered immune system, which can reactivate a previous infection or make it more likely for pregnant women to develop the illness if bitten by a mosquito. Children also under the age of 5 are susceptible. Some baby malaria infection, having acquired the parasite from the mother, not from a mosquito vector. Not only you can become infected with malaria even if you have a normal immune system, but people who have immune system deficiencies, including human immunodeficiency virus, are more likely to experience severe effects of the infection. Let's look at the clinical features in the most dangerous Plasmodium falciparum malaria. There is no pattern of fever. The onset is gradual with malaise, headache, cough, diarrhea, jaundice due to hemolysis, enlargement and tenderness of spleen and liver and thrombocytopenia. The complications of Plasmodium falciparum include cerebral malaria. Swelling in the brain can cause severe brain impairment and damage due to parasite-infected blood cells blocking small blood vessels. This can lead to coma. Damaged red blood cells can result in the development of anemia. A serious complication is pulmonary edema, where a buildup of fluid accumulates in the lungs. This causes problems with breathing. It also causes shock, hemoglobinuria, abortion, and stillbirth. Damage that reaches the spleen, liver, or kidneys can be life-threatening. The spleen can rupture and severe impairment to the function of the liver and kidneys can result in total failure. In Plasmodium vivax, fever initially lasts for hours and then alternates every 48 hours. There is also anemia and enlargement and tenderness of liver and spleen. Plasmodium malariae, the fever is mild and on every third day. Parasite may remain for years causing fever and no other symptoms. Chronic infections may cause glomerulonephritis and nephrotic syndrome. Diagnosis of malaria is made based on the physical examination, symptoms, and blood test. Thick and thin blood smear test remains the gold standard for laboratory confirmation of malaria. The thick film detects the parasites and the thin film determines the malarial species and the percentage of red blood cells infected. PCR amplifies the parasite's DNA and allows better detection and identification of the Plasmodium species. It is more suited for epidemiological studies. Rapid diagnostic tests are also available to detect parasite antigens and are easier to use for staff without microscopy training. Cases also include thrombocytopenia due to low platelet count, elevated lactate dehydrogenase due to hemolysis and anemia. The treatment of malaria depends on severity, age, pregnancy status, malaria resistance, and the Plasmodium species. In uncomplicated Plasmodium falciparum artemisinin combination therapy with quinine and doxycycline or clindamycin is given. In complicated cases, the complications are treated along with artesunate or quinine. Oral chloroquine or primaquine is used in non-falciparum malaria as falciparum is resistant to it. Mefloquine is contraindicated in the first trimester of pregnancy and lactation. Quinine with clindamycin or artemisinin is safe to use in pregnant women. Malaria can be prevented by taking antimalarial tablets when traveling to an area where malaria occurs. Preventing mosquito bites, for example, by using insect repellent and covering the arms and legs. Sleeping under a mosquito net and administering the vaccine to children who live in places where malaria is endemic. Let's look at some questions. A pregnant woman returns from Sudan, now presenting with intermittent fever, rigor, and seizures. What is the diagnosis? Tuberculosis, malaria, meningitis, Lyme disease. Here the travel history and symptoms are to be looked at. The answer is malaria. As the woman returned from Sudan, which is one of the countries where malaria is found, and also the other hint was intermittent fever, which is not in the case of meningitis fever. Let's look at another case. A 5-year-old child came from Ghana 6 weeks ago. 2 days ago he developed fever, vomiting and neck stiffness. He had taken malaria prophylaxis and had no rash. What would the diagnosis in this scenario? Cerebral abscess, cerebral malaria, meningococcal meningitis, subarachnocerebral tumor, pneumonia. Hint in this case is the travel history from Ghana and the signs and symptoms. So in this case the answer is cerebral malaria, as the incubation period of malaria is 7 to 30 days and the 5-year-old came back 6 weeks ago. Even though malarial prophylaxis was given, it does not provide complete protection. Also fever, vomiting and neck stiffness are consistent with the diagnosis of cerebral malaria. Thank you for watching. Hope you enjoyed it. Make sure to like and subscribe for my next video. Hi everybody.